Morning to all of you. Once again, welcome to the teaching session of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we have a journal club, and Dr. Naveen, our resident, would be presenting these articles from journals. And today we have expert faculty with us, Dr. Ravi Mohan. So Dr. Ravi Mohan doesn't need any introduction because he is quite popular amongst us. And he is now the professor of Department of Urology at PGI Chandigarh, which is one of the most prestigious institutes of the country. And he has been the proud recipient of many fellowships, including the Chakravarti Fellowship 2017, JUA Fellowship, EUSP Fellowship, and he has a special interest in uro-oncology and robotic surgery. So welcome, Dr. Ravi Mohan, to our teaching session. Thank you very much. And now I would request Dr. Naveen to kindly go ahead with his presentation. So what we will do is we will just stop after one presentation. We have two presentations, two articles. So after one presentation, we will ask Dr. Ravi Mohan to give his comments, and then we will proceed to the next one. Right. Go ahead.
Yes. Good morning, teachers. Good morning, teachers. And today's first topic is outcome of thulium fiber laser for treatment of urinary tract stone, results of a systematic review. Yeah, it was done by Peter Korenberg et al. And it was published in Current Opinion Urology 2021. And it was done in 3 centers. One is Hospital CUF Descoberts Portugal, Kasturba Medical College Manipal, and University Hospital Southampton. And first of all, introduction. Lasers have become a fundamental aspect of stone treatment, although holmium is current gold standard in the endoscopic laser lithotripsy, but there is a lot of buzz around the new thulium fiber laser also. And currently, super pulse thulium fiber laser machine can provide us with a peak power of 500 watt, and even small energy pulses can also be provided as low as 0.025 joules up to 6 to 8 joules, and they are capable of providing frequency of 2000 hertz. And methods: 60 full text articles and peer-reviewed abstracts were included over the last 2 years in 2019 and 2020, and it was adhered to PRISMA guidelines for this review. And as I said, initially 260 articles were taken, but as during search, if the article was of a non-urological medical specialty, or it was used in non-lithotripsy, or it was of exclusive of holmium laser, and providing providing information about TFL only marginally, those all were excluded, and finally 60 full text articles were included. And these are the results. These results are in comparative way of thulium fiber laser and holmium yak laser. First of all, the machine specification. So thulium fiber laser machine is operated via laser diodes, and it can provide up to 500 watt of energy. And the small pulse energy can be provided as same as holmium yak laser up to 0.226 joule. But the additional value of thulium fiber is that it can provide the very low pulse energy also, up to 0.025 to 0.1 joule. And that can be provided for very long pulse duration also, that is up to 50 milliseconds. Pulse frequency that can be provided is up to 2400 hertz. It can be several times smaller and lighter than the holmium yak laser. There is quite air cooling mechanism with reduced energy consumption, and it connects to any standard electrical power outlet. Now coming to ablation efficiency, it can fragment the stone twice faster than the holmium yak laser, and it can dust 4 to 5 times faster than the holmium yak laser. The dust were of more finer qualities. And about retropulsion, it is seen that with thulium fiber laser there is reduced retropulsion, and better visibility. And about laser fiber, they are smaller, more flexible, and there is more resistant laser fibers for breaking the fiber. And among safety, it can be used in any anatomical location and with in any endoscopic approach. Smaller fragments and less basketing is needed. And about temperature safety, in equivalent power settings, both TFL and Holmium yak laser have no temperature difference. Now discussion, new super pulse thulium fiber laser machines that use electronically modulated laser diodes. They are capable of providing higher and constant peak power, thereby offering wider range of laser parameters. The TFL is called the fiber laser because the laser beam is generated inside a very small core laser fiber within the laser generator. While in case of Holmium yak laser, it was generated inside the laser rod in the resonance chamber. Although Holmium yak laser uses the radiation of 2100 nanometer, the thulium fiber laser uses 1914 nanometer wavelength, but its absorption in water is 4 times higher, which is probably the reason of higher ablation efficiency. Now, although Holmium yak lasers are big, heavy, and power hungry, and they need dedicated high power outlet sources, and the water cooling is noisy. While in case of thulium fiber lasers, uh, while in thulium fiber laser, the machines are several times lighter, smaller, and the air cooling is quiet, and it consumes lesser energy that can be run from a standard power outlet. And now what makes the thulium fiber laser stand out in comparison of Holmium yak laser? It is its capacity to provide higher frequency. While Holmium yak laser can provide us up to 120 hertz, the thulium fiber laser can provide us up to 2000 to 2400 hertz. Now, another innovation concerns pulse duration. Since thulium fiber laser can be operated in both using very low pulse energy, high frequency, and the additional thing is that it can provide very long pulse duration, that is up to 50 millisecond. And about dusting quality, as I said, it can provide us better and finer dust, so reduce the need of basketing and reduces the OT time. And ablation, it is 4 times faster and efficient in ablation frequency. And about retropulsion, at similar pulse energy, stone retropulsion threshold is 4 times higher with thulium fiber laser. The threshold is higher, that means it causes reduced retropulsion than Holmium yak laser. And about energy setting, while Holmium yak laser starts retropulsion at 0.2 joule, the thulium fiber laser starts that retropulsion at around 1 joule energy. One of the safety feature of the thulium fiber laser is its laser fibers are highly resistant to extreme bending diameter, even with higher power settings. Now, the ability of thulium fiber laser to ablate urinary stone in finer particle and smaller residual fragments, it implies less basketing process and maneuverability is higher, so it reduces the OT time. Now, optical setting for fragmentation is 1 to 1.5 joule and 15 to 30 hertz. In case of mini PCNL for dusting, we can provide 1.1 to 0.3 joule and 50 to 100 hertz. And for dusting in the kidney, in case of RIRS, we can give 0.1 to 0.2 joule with 15 to 30 watt. In case of fragmentation in the ureter, 0.2 to 0.5 joule and 10 to 15 watt is used. And for bladder stones, 2 to 5 joule with 5 to 10 hertz is used. Now, safety. There is one concern that it is postulated that the thermal effect is more with the with the thulium fiber laser, as there is more heat production due to more absorption in the water, and that can cause the ureteral stenosis. So what are the preventive measures? We can use the cooled and vigorous irrigation, and we can use intermittent laser, and we can avoid the higher power settings. Now, the advantage of thulium fiber laser over the Holmium yak laser are numerous and ubiquitous, including significant improvements in ablation efficiency, retropulsion, lithotripsy setting, machine factor setting. This thulium fiber laser technology is capable of reducing the OT time and expanding the role of RIRS in treatment of larger kidney stone, changing the current guidelines on stone management. There are some ongoing research like vibrating laser fiber tips, vapor bubble formation, surfactant supplementation of irrigation fluid, and tweaking of the energy pulses. Limitation of the study. As with any new technology, most of references pertain to clinical abstract with very little fully published studies were available. Long-term results are needed to look for, and there is need of multi-centric, multi-regional prospective randomized control trial. Thanks.
Yes, I would now invite Ravi to give first his comments on how he presented the journal, and secondly on the journal itself. So go ahead, Dr. Ravi.
Thank you, sir. Thank you for having me here. It's a learning exercise for me. And congratulations, Naveen. You did a good job. The article is definitely a well-written article, except that it's not a systematic review meta-analysis kind of article. So it's not a level one evidence. What you have is just a summarization of all the abstracts. So that you have to keep in mind. You cannot take very strong messages. What the article hints out is that there is some buzz, and it cannot be ignored. But you still need a level one evidence for it to stand out with respect to other lasers, and I think it's an ongoing work. So congratulations, Naveen, you did a very good presentation. I have a few comments on your slides. They were like paragraph copy from the article. So when you're making a PowerPoint presentation, understand that there should be 4 or 5 lines or 6 lines at max in a single slide. It should not be a paragraph kind of copying. So just remember that would improve your presentation further. And one thing which the authors have ignored very drastically, that there is a significant risk of thermal transmission, and we know that in a small space like ureter, you might actually injure the ureteric mucosa, and they've ignored the comparison of complications between the two procedures. So that is something which is a limitation of the article. You may write it to a letter to editor if you wish to, that and knowing the complications would probably add more value in understanding the things. Thank you, sir.
Thank you, Dr. Ravi, bringing out those important points regarding his presentation. We had again a journal club in which Dr. Apul had also come, and we were just discussing out that yes, when you are just making a presentation of a journal, in fact, you should not read the results and discussion of the author. You should make your own judgment about the results and discussion, how they. So I think it is important that you don't copy paste the things which are there in the article, and you need to make your own kind of points in the presentation. That is very important. And secondly, definitely thulium. It looks like a kind of a article which is almost favoring thulium fiber over holmium, and definitely it is not an actual meta-analysis and a randomized studies which should have been meta-analyzed and given a level one evidence to make it a kind of evidence-based article. So that was again one of the drawback of this article. Um, One about this article basically discussed on the lithotripsy aspect of thulium fiber laser. Definitely, you have rightly pointed out that generating more amount of heat and resulting in probably ureteral stenosis or stricture could be one of the very important complications of thulium fiber over holmium. But what about the enucleation of the prostate? We know HOLEP we are using for enucleation of the prostate, and people have been using THULEP also for enucleation. Uh, any comments on the difference between the two?
Sir, so as you know, I don't do a lot of BPH, But yes, we have thulium fiber laser, high energy thulium fiber, and we do enucleations. The only difference I see that there's a lot of charring in the bed as compared to holmium. But then the advantage is that there is no vibration as you see in the holmium. So it is much easier to learn. The learning curve, I believe, for thulium is much less than what you have for holmium laser. But then there is some amount of charring. The bed seems charred rather than the woolly feel which you have in holmium laser.
Okay. So this we are talking about thulium fiber, not
Yeah,
thulium, right?
yeah, yeah.
Thulium fiber, right? But thulium definitely had that charring. What I remember, thulium fiber also. You are saying that probably produces a lot of
Because
charring.
essentially both are the fiber and this are working on a only conceptual difference is the free pulse frequency.
Yeah.
So one is a continuous laser, other is a pulse laser. But then heat is the primary thing which does cause. So although the claim is that TFL would have less charring than as compared to thulium laser, but the charring is still there.
Okay. Dr. Nachiket and anybody else from the faculty or the residents, if any queries regarding this particular article, please go ahead. I don't see anyone writing anything in the chat box. So if there is no comment or query, we will go ahead with the next article. So Naveen, go ahead with this next article, please.
Yes.
Hi, Dr. Nachiket, just
Yes.
say you hi.
Yeah. Nachiket is probably has gone a little busy. Probably he will come back probably soon. Yes. Yes. Go ahead,
Yes.
Naveen. Yeah.
Yes. Next topic is comparison of vacuum assisted sheath and normal sheath in minimally invasive PCNL, a systematic review and meta-analysis. It was published by Zhu et al. In BMC Urology 2021, and it was done at Health Management Center in Western China. Introduction: for renal stone more than 2 centimeters in size, as per AUA, the PCNL is the standard treatment. However, it is often associated with some complications like blood transfusion, post-op fever, and pneumothorax, as well as bleeding. In 2001, mini PCNL was introduced. That means the sheath size will be 20 French or less. The efficiency of extraction of stone fragments and dust of mini PCNL is lower than that of standard PCNL. Furthermore, the size of sheath and the force of irrigation can lead to a higher incidence of infection and post-op fever. That was the limitation in lithotripsy with mini PCNL. Now, with the development of new technology, vacuum assisted sheath have emerged as newer technology. Here, the stone fragments and the irrigation fluid can be sucked out continuously and contemporarily in the gap between the scope and the sheath. And the methods, the studies were included from the PubMed, Web of Science, Embase, and EBSCO, and the Cochrane library base, and they were adhered to the PRISMA statement. And 3 randomized control trials they have satisfied the inclusion criteria, and they were enrolled in the meta-analysis. The inclusion criteria were: the study design was a randomized control trial. The patient had a history of kidney stone and they underwent minimally invasive PCNL. The intervention approach was a suctioning sheath versus a normal sheath, and the entire text was available. And as I said, initial records included were 126, but due to some reasons like if it was not randomized control trials, or if insufficient data were available, those all records were removed, and finally only 3 randomized control trials were included. In experimental group, in the 3 groups, the number of patients were 91, 311, and 30. The age group in first and second group was nearly 43 years, while in third group it was nearly 52 years. The stone size in first group was in 16.7 plus minus 5.8 mm. In second group, it is around 13.6 plus minus 5.2 centimeter of square, it is area. And in third group, 4.2 plus minus 1 centimeter. The excess sheath used was in first group was 16 French, in second it is 16 to 18 French, in third group it was 20th French. And about lithotripsy, in first group it was Thulium laser, in second it is ultrasound, and in third it was pneumatic and Thulium laser. In control group, the number of patients were in all three groups 91, 304, and 30. The age in first group is around 44 years, in second around 41 years, in third around 51 years. Now the stone size in first group was nearly 15.7 plus minus 6.3 mm. In second group, it is around 13.9 plus minus 4.7 centimeter square. And in third, it is around 3.8 plus minus 1.4 centimeter. The excess sheath and the lithotripsy were same in both groups. Now, data extraction and outcome measures. The baseline information extracted from the original studies include the first author, year of publication, number of patients, age and sex distribution, and data were independently extracted by two investigators, and discrepancies were resolved by consensus. Primary outcome was stone-free rate and perioperative complications like infection rate, blood transfusion, and perforation rate. In secondary outcomes were operative time and hospitalization time. Now the results. In primary outcome, the stone-free rate that was defined as less than or equal to 4 mm residual fragments, and that was measured in first two studies via CT scan and in another by X-ray. And the results indicated that stone-free rate of the vacuum-assisted sheath group was significantly higher than that of conventional sheath group. And about others, results indicated that vacuum-assisted sheath provided better benefit to post-op infection rate, and there was no significant difference in blood transfusion. Only one report in only one first study, they have reported the perforation that was higher with vacuum-assisted sheath, that is 7 out of 91, versus in control group 1 out of 91. Secondary outcomes, operative time. Among these three studies, there was a significantly reduced operating time in the vacuum assisted sheath, and however hospitalization time was slightly higher for vacuum assisted sheath. These are the forest chart. As we can see, in first, stone free rate which was higher in the experimental group on right hand side. In post-op infection, it is reduced in experimental group. Transfusion, it was almost equivalent, and operating time is reduced in our experimental group. The limitations are, authors have not mentioned the number position of stone, and they have not considered the anatomic variation. The number of puncture was not mentioned. Only 3 studies were included, and that too from the same geographical area. The impact of differences in puncture and depth in sheath placement, it was also not assessed, and some missing data were there. In discussion, stone-free rate is the main parameter for judging the efficacy of minimally invasive stone removal surgery. The vacuum-assisted sheath have an improved stone clearance compared to normal sheath. One possible explanation may be due to low negative state of intrapelvic pressure controlled by sheath while flushing and irrigation. The kidney parenchyma shrank, there is decreased tension and improved compliance. Thus, the maneuverability of nephroscope was increased. And when the calyxial neck is narrow or the angle is hard to reach, the sheath can perform lithotripsy and simultaneously suctioning out the fragments, making it a one-step procedure. And it will provide us with a clear surgical field and shorter OT time. In mini PCNL, due to the small size of sheath, in standard sheath where we are not using the vacuum assisted sheath, there the pressure can go even beyond 30 mm Hg, as shown by Zhu et al., which is the reason for more infection and fever. This object can also be taken care of with the use of vacuum assisted sheath. Now the conclusion, the application of vacuum assisted sheath in mini PCNL, it improves the safety and efficiency compared to the conventional sheath. A vacuum assisted sheath significantly increases the stone free rate while reducing the operative time and infection rate. Due to inherent limitation of the included study, large scale, multi-regional, multi-centric prospective RCTs should be performed in future to validate our result. Thanks.
Thank you, Naveen. Again, I would request now Professor Ravi to give his comments, please.
Thank you, sir. Naveen, so this is a level one evidence now. We are talking that it's a properly done meta-analysis. But again, in your presentation, I missed out on the tables and the actual values. When you presented as if it was a conclusion, but you should have given the values. So when you're presenting as a observer, what I'm interested to see what was the mean difference in stone free rate between them and what was the confidence interval. That will tell how the studies are placed. So you just did show the forest plot, but you also should have shown the table as was quoted in the article, because I'm not going to refer back to the article after you present, right? So just remember that when you're presenting a meta-analysis, it is essential that you present all the tables and the forest plots simultaneously. The
Yes, sir.
second thing is what authors have missed it is that they have not graded the risk of bias. So it is very essential when you do a meta-analysis, you assess all the parameters for risk of bias, and there's a platform available called Grade on Revman, where you can presentation was good, fantastic, and one more thing, for all the residents, you should have actually provided a figure of what is this vacuum assisted sheath, because that would have given more value to everyone and understanding. What is this vacuum assisted? How is it being performed? You would have cross references in the articles, because although this article doesn't mention that figure and technique, but you could have given that for the benefit of residents. Thank you, sir.
Thank you, Ravi. So definitely, you made some very important points regarding the article and how to present that journal club and to include the tables, which are very important to do a comparative study. So, a few things that I could just make out from the presentation and the article was the three groups that were taken. The first two groups, the stone size was less than 2 centimeters. It was 1.5, even less than one. So, which is not an ideal indication for PCNL. So, I think these two probably because we need to have a more larger size stones in PCNL to have a better kind of study. Only the third group had stone size which was larger than 1.5 and 2 centimeter. And secondly, they used the third group, they used also pneumatic and both Holmium. Probably because the size was larger, so they wanted to use pneumatic also. Now, one thing that I feel could be the limitation of vacuum assisted sheath is that when you do a continuous suction, then the visibility may reduce sometimes, because the irrigation fluid is continuously sucked out, and the visibility of the stone, if there is slight oozing around, maybe a slightly limitation. So that what we have also, we have a very limited experience of vacuum assisted sheath, but in whatever we could see, that is probably one of the limitation, the visibility. Secondly, if the stone is dusted, then they will definitely come out around the nephroscope, in between the space between the sheath and the nephroscope. But if there are fragments, they would not. So what we do is we intermittently remove the nephroscope, and this vacuum usually gets the small fragments out also. So that is the way I think we should do if you want to remove those small fragments also with the vacuum system. So I think this is again very important. And the third group had a 20 French sheath, so which is very near to the 24 French sheath which we often use in a standard conventional PCNL. So again, I think there are a lot many things in our experience. What we have seen, definitely mini PCNL is a very good innovation after the conventional PCNL. But the size of stones that we usually deal with, most of them are staghorn, and many of them are very hard stones. I don't know, in the West, they do not probably have those kind of stones. So it is very difficult to dust them by laser. So if you want to do a mini PCNL and dust these fragments, becomes very so, and it may be very stag on maybe in 30, 40, 50 minutes, will take maybe 2, 3 hours to do with a mini PCNL. So, which is again probably can increase the complication rate in form of infection and all that. So, any comments, Ravi? Yes.
Yeah, I perfectly agree, sir. I think the kind of stones any institute deals in India are much bigger than what have been what the. In fact, even in private practices, they deal with the smaller stones, much smaller stones. Typically, institutional practice we would have more complex and more larger stones, and your OT time is always at constraint. So we need something which is faster. I think TFL might have an advantage there because it does increase your stone fragmentation speed and the dusting part. So it might have advantages there. Otherwise, whatever we are doing is exactly the same as you said. That we would remove the scope in between, put a section, and suck all the small fragments, and again get back in. Yeah.
Right, right. So whenever when I people tell about mini PCNL and tell so many advantages of mini PCNL, I just wonder that I just want a comparative workshop. Two cases with a 24 French and then 18 French or 16 French sheath, and doing a staghorn PCNL, both with mini and conventional. Let's see which one is probably better, because what I feel what we are doing is more, usually a standard conventional PCNL, and we do not find any complication with as the standard PCNL, as it is said that the bleeding is more and all that, those things. We hardly see any life-threatening bleeding. Definitely there is oozing and all that, which usually stops maybe within a few hours only. So that, anyway, Nachiket is there. So Ravi was wishing you, Nachiket. You were just
Sir,
out.
yes.
Yeah, yeah.
Sir, yesterday inside the OT, we were talking about Ravi, that
Yeah.
Neeraj was telling us that he's a great surgeon, and Jodhpur conference mein he demonstrated a VVF. So Kali, all of us were speaking very fondly about him, and it's a honor and a pleasure that he came inside the teaching session, and the residents would have immensely benefited with his presence. And thank you, Ravi. And
Thank you.
it's always a pleasure listening to you, your words of wisdom. And I think that we'd be happy having you again. And thank you for coming over.
Thank you.
Thank you, Nachiket. Yes, exactly the thing that was said by just we were discussing, that you did a very good robotic VVF repair. Good, and we wish you all the best, Ravi. And Ravi has consented us to come again, maybe a couple of weeks later in the month of December, at the end of December. So we are looking forward to this, Ravi. And thank you very much to joining this session today.
Thank you.
Any last comments from you, and then we will wrap up the session.
No, it's the pleasure and honor is mine, sir, to be a part of this teaching session. It was, and I felt as if we were sitting in our own journal club. So absolutely enjoyed it. Thank you, sir.
Thank you, Professor Ravi Mohan from PGI Chandigarh, and thanks all the faculty members and residents and all those viewers who might have joined us today on Zoom and YouTube. Thank you very much, and have a good day. Thank you.
Have a good day, sir. Good day.